we would like to welcome everyone to our webinar for today entitled Understanding Universal Healthcare and Diagnosis Related Groups. So this is the part two of this webinar. And just a quick recap of what were discussed in the first part. So we were able to discuss the UHC Act, the integration of local health systems into citywide and province-wide health networks. And today we'll be continuing on the discussion on the diagnosis-related groups, or the DRGs. So without further ado, let me welcome our speaker for today. Our speaker is the Senior Vice President of Health with a special assignment on the UHC Policy Development Team. So let us all welcome Dr. Israel Pargas. Let's give Doc Ish a virtual round of applause. Good morning, Doc Ish.
Hello, good morning. Yeah, good morning, and thank you for welcoming me back again. This will be the lecture on the DRG, although we have started this last week, but unfortunately we were not able to finish it. So we will continue today. So nakakaaliw lang because yesterday I am with the Mount Grace group of hospitals together with Unilab for a UHC summit, and now today it's with another group, the QualiMed. Let me share my presentation. Okay, so can you see the slides?
Yes, sir.
Okay, thank you. So again, thank you to QualiMed for the invite, and of course to Dr. Regina Nazareth, who actually facilitated this. So I am not an expert, but I was invited to give a lecture on this DRG. So every one of us is like in a journey now learning the DRG, especially in the adoption for the UHC, under the UHC as a provider payment mechanism. So I actually have started this lecture last week, but we were not able to finish it because of technical difficulties. Ganyan talaga yata po pagka live. Why is not moving? Okay. So we are going to use the diagnosis-related groupings as espoused in Section 18B of the UHC IRR and the law that PhilHealth shall now endeavor to shift to a prospective type of payment mechanism, which is performance-driven, closed-end, and using diagnosis-related groupings based on validated costing methodologies. So in effect, what is a provider payment mechanism? Well, technically, it is how we actually purchase the services, and you, as health facilities, are the ones providing the services to our members, and we will purchase that. So how much, how often, what will be the incentives and disincentives in order to, of course, drive the desired provider behavior, no? And at the end of the day, the provider behavior that we want is really to provide, to make sure that the members are actually, one, getting the quality of services that should be provided to them. So the provider payment mechanism should ensure that these members are actually provided with a quality of care, and at the end of the day, to provide financial protections. It's also a cost protective mechanism. For the providers like you, especially the healthcare providers, it should be a mechanism that would actually incentivize you to provide such quality services. So meaning you provide the much needed services at quality at that. So there should be enough incentives for you to provide those, and enough disincentives also to not to over provide and overutilize such. And of course, for PhilHealth, it should be a sustainable mechanism. Now, just to review, what will be the goals for the responsive payment mechanism? It should make sure that, of course, there are available resources. Again, that is to make sure that the quality of services are provided. There should, at the end of the day, a provision of good health outcomes, minimization of adverse events, and of course, Um, at the end of the day, we should optimize, of course, the patient convenience also, especially in the provision of financial protection. Kung makikita po ninyo, there are different types of responsive payment or payment schemes. No, there is a like budget, especially katulad po sa mga private sector, you provide budgets. For the government, we provide line item budgets. There are several types of payment mechanism, like the capitation, if you have heard of that. So right now we're using that, paying our consulta or our primary care services, the case-based payments, just like what we are doing right now in the case rates, the fee for service. This is what we have adopted before, wherein we pay for every service that you provide. But there are a lot, of course, of um, um disincentives with regards to fee for service or per diem or per day, and of course salary, especially for example those who are employed. So but right now, again, what we are adopting would be a prospective type of payment mechanism, and an example of that would be your DRG or your global budget. Now in the Philippines, especially under PhilHealth, the payment systems we have adapted before are the fee for service, capitation, and of course currently the case rate, and we are moving towards the DRG. So kung matatandaan nyo po, we started the case rates in 2011 with the top 23 medical and surgical cases, and then in 2013, all has been paid under the case rates. Although, kung matatandaan nyo rin, even before 2011, we have been using case rates for some packages like maternity cases. Now, again, this is just a mandated under the law, the provider payment transition. And the more important phrases here under Section 18B is paying providers using one, performance-driven, close-end, it's a prospective type of payment mechanism, and identified po kasi sa batas yung diagnosis-related groupings. And so this is the topic for today. But I would like to, because I think there are a lot of professionals who are here, the law also provides that our payment mechanism should have no or without differentiating facility and professional fees. Okay? And at the end of the day, what we want to achieve is that it should give due recognition or consideration to providing service quality, efficiencies, and equities. So, ibig sabihin po, we will pay. Of course, we will purchase the services that you provide, but it should also be performance driven, or there will be, of course, set up of performance indicators under negotiations, of course, because again, what we want is to measure quality. Very important also is that there should be validated costing methodologies. So even if even if before we can actually develop our DRGs, and we should first go into costing or costing methodologies. And right now, that's the first activity that we are actually doing under PhilHealth. We're doing the costing together with our development partners, the ThinkWell, the USAID, the World Bank, and of course with other stakeholders like the medical societies and hospitals. We have made the first round of costing, and so we are able to get the direct and indirect costs coming from the hospitals and of course the doctors. And we are doing the cost analysis right now so that we can actually come up hopefully with an approximate cost of healthcare. But we are also going to have the second round of costing and third round of costing. So I would like to express sana the request, if you are for example asked to be a part of this exercise, please do so that we can actually get the cost of the healthcare right now. Otherwise, we won't have any cost that would be coming from the providers just like you. Now, why do we need to change the DRGs? Well, again, as it is mandated by law, but we also want to be more responsive, especially to the patient needs, because one of the mandate really is to provide financial protection. But how can we provide enough financial protection if the patient needs are not technically, especially on the finances, are not met? No, so kailangan talaga nating ma-cost ng maayos at makapagbayad din tayo ng maayos para masigurado na yun pong financial protection or yung pong kailangan bayadan natin ay nababayadan natin ng tama. And because also we need to respond to the fact that patient needs or patient's treatment of care is very complex. It's not just a single case, katulad po na nangyayari ngayon sa case rate, na kung CS ka, CS yung babayadan natin. Pero paano kung may mga complications? Or paano kung merong other factors that actually add to the complexity of the treatment or of the episode of care? So we want to be responsive to that. And the responsiveness would actually be need to be flexible to the resources being used, especially for those other complications and other services that are provided to the patient, not just for the procedure. Okay, so we need to respond also to adjustments over time, like the inflation, medical inflation, and not just on the medical inflation, but inflation as a whole. Now, what is the overall direction for the provider payment mechanism? So from all case rates, although right now we are also having a review on this case rates, but as we transition, because as we need to transition to DRGs and global budget payment mechanism as the preferred prospective type of payment mechanism under the UHC, hopefully we can also improve on our case rates transitioning to DRG. So we are going to use the DRG as our payment mechanism for the inpatient care. And for the outpatient, it is going to be our capitation still. Now, DRG plus the capitation, DRG for the inpatient plus the capitation for the outpatient would equal to the global budget. And this global budget is the one that we are going to pay to our healthcare provider networks. Okay, there would be some terminologies to remember para lang hindi tayo mag-mix up, the case mix, case-based payments, kasi po para medyo guided din lang tayo. The case mix technically is a patient classification. And this is actually a tool to improve financial and clinical management in a facility. So, ano bang type of or mix of patients na meron, for example, ang mga QualiMed facilities in its hospital or in some of its units. And ang case-based payment naman po is technically the way we pay. No? So we pay the hospitals and the physicians according to the cases treated. Okay, so it's a per case rather than per service or per bed per day. Tatandaan po natin that the case payment can be a single flat rate per case, but in most cases, it is based on the schedule of payment by diagnosis. So technically po, DRG is a more complex case payment type of mechanism. So ngayon, what we are doing is a case rate, which is also a case payment. We are shifting to another case payment, which is more complex, the DRG. But what is the difference? Kasi kung yung case rate, may mga issues na tayo as a case payment type of payment mechanism, pero bakit case payment pa rin yung gagawin natin? So meron naman pong mga differences that we will adopt. So the DRGs, this is the history. Hindi lang naman po ngayon tayo nag-aaral on the DRG. We actually started in 2000 when we did the initial work for a partnership with a development partner. And then sometime in 2009, we were able to develop our case-based groupings together with the University of United Nations University in Malaysia. So we were able to have 314 groups, especially for the Philippines, but we were not able to use it. And eventually we started with case rates first as a transition. And then now we are again doing the DRGs as a spouse in the government mandated law. So case-based groups system, and it's a DRG. So ito yung sinasabi natin. The bigger group is the case-based payment. And the more specific one is the DRG. It's a more complex and specific form of a case-based group. It is also patient classification, but this time this is based on a set of several variables to define the grouping. Take note that the DRG is a classification that uses algorithm. And this algorithm, that's why the DRG is heavily dependent on some specialized software, which we call the grouper software. And this This is a digitalized case assignments software kasi po the diagnosis together or against its resources being used in the treatment of care are actually grouped into one such that there could be clinical homogeneity, and with that the diseases are grouped accordingly together with the same sources that resources that are being used. So it is a case against the costs being incurred by the hospital. So, ganun lang po siya technically kasimple. The diagnoses are related as one, and the resources being used are also related as one. Okay? So, the more important thing is the DRGs actually represents a class of inpatients wherein there are similar clinical conditions. That's why they are related as groups, and similar resources inputs. Again, that's why they are related as groups. So hindi lang po yung clinical condition, but the resources being used are also almost similar. Kaya po siya nag-group into one. Okay? So ganun po yun. And there are several types of DRGs, the basic DRGs, all patient refined. Iba-iba din naman yung nagiging tawag sa kanya. But definitely, pare-pareho po siya representing a similar clinical condition, similar resource inputs. So again, the purpose of the DRG is to make sure that there is more efficiencies, especially on the use of your resource demands. So the hospital case mix or the hospital patients classification would now be related to the resource demands and the costs being used by the hospital. So technically, it's a tool to make things more efficient, especially in the operations of the hospitals and in the treatment of care of our patients. Now, a DRG would have several components, especially in its development. And the more important thing, the first important component of the DRG funding system really are the data elements, because the DRGs would need to be, again, the cases need to be assigned to the grouping, to the specific related grouping. And so it is very important that we have these data elements. For example, the codes. Right now we are using ICD-10 for our medical coding system. So we need the principal diagnosis, other additional diagnosis to make sure that the complications and other resources being used to treat the diagnosis are present, complications, comorbidities, length of stay, admissions, the modes of separation or the discharge status, and of course the same day status, even the sex, because there are some resources necessary accordingly to the sex types. So these elements are very important, especially the codes. So right now, so kung titingnan po natin, we are abreast with ICD-10 codes, but the health system is moving towards another ICD-11. And this ICD-11, I think technically is more digitalized. Right now for the procedures, we are using the Philippine RVS or the relative value scale, but to make this more adaptive to world classification, we are shifting to the procedural coding being utilized nationwide. So medyo marami po tayong magiging preparation, especially on the coding type. And these are actually very important. Kasi nga po, kung kulang-kulang, kung mali-mali, yung ating mga nagiging diagnosis and yung ating nagiging code relative to this diagnosis, then technically, even po yung pag-group or pag-assign ng DRG codes will actually be, well, mishap or magiging mali din. That's why I think nabanggit kanina ni Dr. Annie, there are, of course, doctors here, there are interns or probably residents also, and of course the consultants. It is of course our job to write the correct and complete diagnosis. Probably some or other people are doing the coding, but their coding would actually depend on our diagnosis. So it is very important that we write all the correct and complete diagnosis so that the codes that will be used or utilized will actually be present and complete also. So there will be a more accurate grouping that will happen. Another component, of course, of the DRG funding system is the cost, the price. So what are the resources being used? So this will include the prices or the cost technically of professional fees, drugs and medicines, lab, x-ray, diagnostics, rooms, anesthesia. And basically these are your direct costs. But there are also needed indirect costs like your utilities, your water bills, your electricities, your rentals, all those, your salaries, all those are actually part of the resources being used to provide a treatment or an episode of care to a patient. Hindi lang naman po itong mga direct na ito ang ginagamit natin sa titreat ng isang pasyente. So nandyan yung tao natin, nandyan yung kama, nandyan yung electricity na ginagamit, yung pong space or yung lugar, all those indirect costs are actually part of the resources being used, and these are very important. Kaya po dun sa costing methodology, it's not just the direct costs that are actually being gathered, but also those which would include the indirect costs. So the resource intensities as part of this would include your other attributes like length of stay, the diagnosis and the procedures being utilized, and of course, again, as I've said earlier, the discharge status. So, gaya po na nabanggit ko, the DRG is also a case-based payment. But what is the difference between the case rate right now that we are using? Well, the DRGs would be more responsive and more accurate than the case rates. Because the case rates right now are fixed for each ICD-10 or RVS code. So katulad po nun, gaya na, kung ito ay pneumonia, we will pay for the pneumonia. Kung meron siyang other complications that like hypertension or diabetes, hindi siya nako-consider. Di po ba ang ginagamit natin ngayon is just the principal diagnosis? Or halimbawa surgical procedure. It's the principal surgery na ginagawa, but the other surgeries, except in some or except for some, ay hindi naman natin nakakasama sa computation ng case rate. Pero pagdating po sa DRGs, naiisama or maiisama na po siya. Okay? That will be considered under the adjustments. So another component would be the codes, gaya ng binanggit ko kanina. The ICD-10 code or later the ICD-11, the procedural codes, the RBS, or the procedural coding that we will shift into later. These are very important. Again, there is such thing as a grouper software. So very important po ang magkakaroon ng dapat effective information management system that is on the DRGs itself. But prior to the DRGs mismo, kailangan pa rin natin ng very good information management system because again, we need all those costs. And those costs can actually be easily provided if we have a good information management system. Sa loob po yan. Kasi nga, a DRG, if we want to respond, especially to inflation and to changes over time, then we need to review all our data every now and then, yearly, every 2 years, every 3 years, and we need to have those data present at all times. And all these data can just be provided through an effective information management system. So any health data or any health-related data that can be used to provide information for an update on the elements we need for a DRG should be present at all times. Okay. So again, the more important thing here is that a DRG should contain patients with similar pattern of resource intensities. No, so again, this is a grouping of similar conditions with similar resource intensities. Okay. It should be clinically coherent. So again, it should be of similar conditions. And with that, mas madali nating pag-uusapan or mas madaling mapag-uusapan within the community, within our healthcare provider community, pag pinag-uusapan na natin yung DRG kasi it speaks of the same resource use, same clinical condition, or at least the same clinical perspectives. So far, Ito naman po yung worldwide. Yung top 10 DRGs are here: the normal newborn, vaginal delivery, heart failure, psychosis. So kung titingnan natin, well, siguro hindi natin masyadong familiar here in the Philippines, but psychosis is in the top 10 DRGs. So ibig sabihin worldwide, maraming cases belonging under this psychosis. Of course, the CS and the rest of the gang. Now, ano bang itsura ng DRG? So ang DRG again is a code, no? So coding po siya, and this will be composed of a major diagnostic category code, an adjacent DRG code, and a split indicator. Okay? Normally, the major diagnostic category would represent a specific body system. The adjacent surgery or the adjacent DRG would represent if it's a medical or a surgical procedure or any partnership between the two. And the split indicator would actually identify importance in terms of resource consumption. For example, complicated, severe, moderate, mild, so may mga ganon. That would actually define some of relativities in the resource consumption doon po sa mga diagnosis na ginamit. But ganito po ang mga kalimitang itsura ng DRG. Okay? So in the example, for the D being the major diagnostic group that would represent a body system, halimbawa po ay ear, nose, mouth, throat, and the rest. The adjacent could be a procedure. So for example, ang 11 is a procedure, and that would correspond to tonsillectomy and or adenidectomy. Ang split indicator Z would represent there is no variance in the resource consumption. Ibig sabihin, uncomplicated, regular. Regular siya, uncomplicated, walang ibang difference in the resource being used. Ibig sabihin, walang comorbidities, or even the procedure itself is a successful, being no other complications. So, regular siya, D11C. So, mga ganun po. Ngayon, kung halimbawa, mayroong variance in the resource consumption, mayroong halimbawa, additional, may hypertension. So, dun magbabago sa split indicator. Or halimbawa, it's ear, nose, mouth, and throat, pero hindi siya tonsillectomy, but another procedure that would be under the mouth, for example, then 11 is changed to another number. Okay? So the split indicators, gaya ng nabanggit ko, would represent the variances in the resource use. So pwedeng ang representation natin is A, B, C, D, and Z. A being the highest consumption of resources, for example, the severe, and then B, the second highest consumption down the line, and the Z would be the no variance. So examples of which, so ganyan po yung mangyayari. So ganun din po, no? May major diagnostic, then the second DRG is the procedure or diagnostic cluster kung ito ay medical, and then disease cluster kung ito ay kung ano yung procedure, and then of course yung kung the fourth would be the third would be the split indicator, and the fourth is the code already. So for example, DRG E65 would represent a chronic obstructive airway disease. And as it is, nagroup po siya kasama sa group ng chronic obstructive airway disease of similar condition characteristics would be the bronchitis, the emphysema, the COPD, and the bronchiectasis. So saan siya mag-iiba-iba? Pwede siya mag-iba-iba doon sa next DRG, which would be for the variances in the resources being used. So halimbawa po, constructive obstructive airway disease is the main DRG, the E65. And then, pwede pong magkaroon, di ba, natatandaan nyo yung ating split indicator, or the fourth one would be, A would be the highest, B would be the second highest. So, kung ang diagnosis is chronic obstructive airway disease with catastrophic or severe complications, then A yung ating split indicator. Kung halimbawa naman po without catastrophic or not severe or without severity, then B, pwedeng maging B. Under this chronic obstructive airway diseases, what could be grouped as principal diagnosis would be the following. Lahat po yung nanadya dyan using the ICD-10 codes, of course. Then, magkakaroon ng differences on the variances on the resources being used. So, sa atin po sa DRGs, sa ngayon, using the ACR, we have, I think, more than 4,000 medical case rates and more than 4,000 procedures. So, coming up with diagnosis-related groupings, then magkakaroon ng clinical groups depending on its homogeneity. Then ideally, baka po yung ating 4,000 plus 4,000 would be reduced into around 500 to 1,000 diagnostic groupings. So even administratively from our side and from your side, it would be easier than the ACR. Now, again, what would be the main difference? The clinical or physical attributes will be classified as modifiers. Yun pong sa ACR, wala po tayong modifier, wala tayong adjustment that will affect the cost of care. So it is the same, the support value or the provision of payment is the same for both simple and complex cases. So example ko kanina is CS and CS with hypertension or diabetes. So isa lang yung binabayatan natin dyan, whether it's simple or it's a complicated one. But under the DRGs, there will now be the use of modifiers that will be your physical attributes and clinical attributes to represent your comorbidities. And there will be adjustment factors that will actually affect the cost of care. So the support value or the payment mechanism would vary across cases. Okay? So example, indicative example po, pneumonia, moderate risk. Ang ating current dyan is J18.92. So, sa case rates po, for example, it is at 15,000. Example lang po ito ha. So, ang patient natin at age 17, walang complications. Pwede pong ang resulting rates is at 12,000. Ngayon, kung ang pasyente is at 68, female, and a hypertensive at that, kung sa ACR, still at 15,000. Pero with the adjustment factor having the age, the hypertension, pwede pong ang resulting DRG na is at 25,000. Another example is a male 72 patient, hypertensive, at the same time diabetic. Kung ikaw ay ACR, still, ang consideration lang natin is the moderate risk at 15,000. Example, if that's the amount that we pay. Pero kung sa DRGs po, pwedeng ang computation na niya is at 40,000. Considering the adjustments for the modifiers as age, complications, and comorbidities like hypertensive and diabetes. So yan po yung main difference kung titingnan natin pagdating sa computation ng ACR and DRGs. Again, the DRG would actually compute also for the resources being used represented by all other attributes sa pasyente at dun sa sakit. Okay? So yung issue natin na paano yung mga ibang nagamit ko or paano yung sakit ng iba ng pasyente. So ibig sabihin, pagdating po sa DRG, na ipapasok na po natin siya. Okay? So yun po yung isa sa mga main differences. Although they are both case-based, again, yun pong sa DRGs, meron siyang modifiers. So just to go back to the issue on prospective type of payment mechanism. Ang prospective type of payment mechanism po kasi is technically may dalawa siyang attributes. One is it is predetermined. So parehong predetermined. Case rate is predetermined right now. Katulad na yan, pagka na-confine ng pasyente, alam na niya magkano ang CS. DRG is also predetermined as one of the one of the factors or attributes of a prospective type of payment mechanism. So it makes things more predictable. Alam ng pasyente kung magkano. But the main difference, again, is the resource used being now factored in under the DRG. Now, the second attribute of a prospective type of mechanism is the timing of the payment. So it could be after the services are provided or even before the services are provided. So in that case, also we are looking as one of our reforms is the payment of services prior to it being given. So it's a front loading of money. We are in discussions right now with COA and the Department of Finance and DBM on how to go about this because it is being now provided under the UHC law, the prospective type of payment mechanism. So we are also looking into that reform that we can actually front load the money to all our contracted networks. Now, how do we compute for the DRGs? Of course, coming from the validated costing methodologies, because this is again a predetermined rates, then there will be cost weights. So yun pong mga cost weights natin would be based on the cost that we will get from you, and we will average that, especially on the average cost of all these charges in a specific grouping. And this will again be dependent upon the average cost of inputs like nursing, procedures, allied healthcare required for the appropriate health patient outcome. So take note, it is not just the direct, but also the indirect. So meron pong magiging predetermined cost rates, no? Or cost weights ang isang bawat DRG. Okay, so this is just an example. So for example, E65 is at 36 average cost for DRG's E65, and the aggregate average cost for all the diseases under that is this. So the weight for each DRG is at 45, and that will be multiplied to later a basic rate or predetermined fixed rate. So yun pong base payment rate naman, this will include the labor and non-labor portion. Again, dito po pumapasok also yung part ng modifier natin na hindi lang naman siya on the patient or clinical attributes. Magkakaroon din po ng factors or adjustments pagdating dun sa mga wage indices. Pwedeng mag-iba-iba. Pwede nating iba sa NCR. Pwedeng iba sa urban or sa rural area. Pwede ring iba sa type of facilities, kung level 1, level 2, or level 3, kung teaching or non-teaching, pwede po natin gamitin yon as our adjustment rates, no? So that there is a base payment rate for that being computed also. So katulad po nung nabanggit natin, kaya po kung makikita ninyo kanina sa case rates, it relatively is constant at 15,000, pero doon sa DRG, nag-iba-iba na rin yung amount because of the input of the cost weights and the base hospital weights. Okay? So, sa use po ng DRGs as a system, marami naman ang gumagamit nito. Technically, right now, under the movement of the health system, DRGs, the global budget, the prospective payment mechanism is the preferred one. And sa development po, siguro hindi naman tayo nahuhuli, although it's taking a longer time for us because we started in 2000. And now it's 2022, we are still doing. Although, of course, there are policy directions which affected, but we are hopefully, because this is now mandated by law, we are bent on moving towards the adoption of the DRGs. So kung familiar po kayo, just recently may lumabas na po na guiding principle or the guiding principle of transitioning all case rates to a DRG. Meron na pong PhilHealth circular noon. I think na-publish siya last week. And then around 2 weeks ago, meron din na pong lumabas na circular on the costing on the costing methodology So please read on those para po medyo makita rin nyo. Although the requirements would be very granular too. But of course, others would say masyado namang very specific to, but of course, they should be covered by the Data Privacy Act. Now, what would be the challenges in the shifting towards a new provider payment mechanism? Well, first and foremost, it would be the readiness of both sides, PhilHealth and of course the providers. For PhilHealth, of course, priorities and directions, these are policies, costing and methodology, because again, before we can even go and develop the DRGs, we should have a correct and validated costing using correct costing and through the validated methodologies. We should have the appropriate codings and the practice guidelines, because again, that will be important in order for us to group the diseases accordingly and the resources accordingly. This is heavily IT infrastructure dependent. And of course, we should have our own Philippine DRGs. Although in the Asian setup, pwede naman pong nating tayong so far mag-adopt, which we are doing right now. Probably we are adopting first the Thailand DRG until such time that we will have and develop our own DRG, because at least ang setup naman natin amongst the Asian is almost the same. And of course would be funding and technical support. For the providers, well, they should shift from paper-based system to a more highly technical information management system. I don't know if it's going to be a problem, but it is a challenge to share your data. I have talked with some, and they are saying most of the data, especially the cost, would be their operational data. So baka naman ma-share siya and all. But of course, we are governed by the Data Privacy Act. Adherence to CPGs and pathways, we know that. Sa linya po ng ating mga providers, how often and how accurate are they following the CPGs and pathways? Or since this is their professional work, as they say, the doctors know best, but of course, there are CPGs, pathways, treatment protocols that we need to follow. So how strict are we in following them? The quality of coding, again, as I've said, is very important. And not just the coding, but really the writing and the issuance of the diagnosis itself. Because the quality of coding will actually depend on the diagnosis that we, doctors or providers, actually write or identify as per case. And acceptance of the shifting of payment systems. We know for a fact that there are a lot of probably issues with regard to our reimbursements, to our payment, on the timing, on the amount. And so we need to recognize that it should be a hard sell, or it will be a hard sell for the for us to the providers to accept changes in the new provider payment mechanism. What will be the struggles after the challenges? So for the doctors, example, well, you have to do and document. That's the diagnosis itself, and code how sick the patient is, or probably someone is doing the code, but that will actually depend on your documentation, on your diagnosis. Assigning the correct DRGs, and of course, again, the CPGs, the clinical protocols. For us naman is assigning the appropriate cost, like the payer. Kasi syempre, what we want naman is, una, it should be a sustainable mechanism. Second is, we should be able to at least approximate the cost such that we can actually provide the financial protection to our members. Monitoring and controlling the moral hazards, and of course, at the end of the day, the decrease of out-of-pocket. For both of us, we need a robust IT system. We need the correct costing data, the correct and true costing data. So we need to be transparent on this. We need to ensure equity to all our members. And of course, the availability of funds on the side of PhilHealth, of course, because we know for a fact that probably it would increase the amount of payments that we have. And for the providers, of course, there should be a correct timing on the fund flow coming from the payers like us. So sana yung pong mga issues natin on the delayed payments dapat should also be answered, no? Containing costs without compromising the quality of care. We want it to be a sustainable mechanism. So meron din po mga issues dito na baka naman because this is a cost containment procedure also, but hopefully the quality of care being provided is not compromised. So in summary, the DRGs should be manageable and again should be clinically coherent against the use of the resources. And this should make the hospital more efficient in its operations. This should be defined or based on the principal diagnosis, secondary diagnosis, on the procedures, on the clinical attributes of the patients and all. So dapat po ay klarado yan and defined. This will hopefully provide a better understanding for the hospitals on their case mix and the demands of the resources. And this is actually an evolving process. So as we change coding schemes, as we go along this, there will be more comprehensive data coming year in and year out. So this is an evolving process and it should be reviewed over time. Again, because of other factors like inflation. So this is a development in process. So I think that is my last slide. And these are some of the references that we have used. Also, thank you to Dr. Valera for some of the inputs on the slides. And so, yan po ang overview of what a DRG looks like, how it is being done. And although, again, this is heavily dependent on the IT. So thank you very much for listening. And hopefully, when we are in the process already of producing the DRGs, then again, the QualiMed is or will actually take an active part, and your societies will actually take an active part in the development of the DRGs. Not just in the development of the DRGs, but right now on its infancy stage, the costing methodology. So thank you very much and good morning.
Thank you very much, Doc Ish. It was a very comprehensive discussion. So thank you po for making time to discuss this with us. So now we'll be moving on to our question and answer portion. So if you have any questions, please input it in our chat box so we can ask Doc Ish your questions. So personally, sir, I think it's yung shift to DRGs, it's parang it's a shorthand already of giving the assessment and the clinical picture of the patient in one code. So it would be very helpful for our medical practitioners in the future when we already shift to the DRGs. And it's also taking note of the additional factors like comorbidities, other factors that would affect the assessment um, or the management of the patient.
Yes,
So
and for us managers, hospital administrators and all, it would also be very good as an input to make our operations more efficient because we already know the resources and we can actually equate this to the demands of a patient. So mas nag-group natin, mas nare-regroup natin But again, hopefully this will not in any way compromise the quality of care that we are providing.
I agree, sir. Sir, we have a question po in the chat box. They would like to know how far are we at the implementation, the tooling, retooling, or the pilot or scoping?
Yes. Again, so far we have, other than this types of capacity building and information giving, so far the first stage that we are doing right now is, other than coming out with the policies, the governing policies, we are in the first step of doing our costing, because even before we can do the DRGs, we should have the correct cost data para po may pasok natin and makompute yung DRG. So we already have finished the first costing, done with around, I think, 20 or 22 healthcare facility hospitals that is represented by around 12 government and 8 private hospitals. And we are doing the cost analysis right now. Hopefully, when we finish with that, we can start the second round of costing that should include more facilities. And again, as I call for a request to, if ever you will be requested or called to participate, please do so, because we really need the correct and true data, especially on the cost, so that we can approximate the cost of care. So other than that, we are being helped by development partners. We have technical assistances coming from the Think Well Philippines, the USAID, the WHO, and the World Bank on this. So meron po tayong mga nakapasok. Some other uh, societies like the PCS are actually doing their exercise activities already on this, so that they can help provide us with some of the data already. So hopefully you can also do that. So yun po, nadun po tayo doon. So we have come out with the policy governing circular. We have achieved already some of the board approvals on the adoption of the software. And hopefully, sorry, hindi ko lang yata na ipakita dito yung the 6-year, no, the 5-year um, operational plan. But every year, meron po tayong deliverables. But so far right now, nandun po tayo sa stage ng having the cost until we go into the DRGs, the development really of the DRGs. Yeah.
Thank you, Doc Ish. We have follow-up questions lang po. Regarding the sharing of costing, can aggregate reports suffice daw po?
Actually, kung titingnan po ninyo yung, what we really need is hindi siya, dapat nga po disaggregated eh. Kasi we need to compute for each cost weight. So hindi lang siya relative kasi. So we need the data for the indirect, the direct. So kung makikita po ninyo yung pinalabas nating circular for the costing methodology, mas granular po yung hinihingi nating data. Although may reservation yung iba, baka naman nga kasi dahil granular na siya, and syempre these are data. I don't know if it's a secret data from the providers or from the hospitals, but we are governed naman by our Data Privacy Act. So we prefer, and actually what we need are the granular data po. So mas mahirap kung aggregate data lang siya. It should be actually disaggregated.
Disaggregated. Thank you, sir. Another question po from our chat box. How often is the contemplated iteration of the algorithm, or is this AI assisted and is automatic?
We are looking the review of every 2 or 3 years. Of course, ideally it should be yearly, but as we move along, because this is a developmental progress, we would probably, and as we become more efficient in doing it, and as we adapt more to the IT use, then we are looking into every 2 years first, and then hopefully it would be every year because the inflation is like happening every now and then. So kaya po, even at the level of the contracting, kasi dun sa contract po is wait, even po dun sa contract po natin, every year kasi the global budget would of course be different. So ibig sabihin, nire-review po natin, and the input for the global budget is coming from the DRGs. So dapat nare-review din po natin siya. So hopefully we can come to terms of every year, but that would probably be an administrative work, very very hard administrative work for us right now because we are still in the learning process, just like kayo po. So may sama tayo sa journey na ito. So we are looking into first every 2 or 3 years.
Thank you, Doc Ish. Siguro po we'll be asking the last question in the interest of time. The last question po is, if front-loading is contemplated, will the DRG costing evaluated at a discount?
Pwede po nating tingnan in a way na ganyan, or we can probably be it's a front loading, but we can also because it's also a performance based, we can provide this in tranches. We can also provide not really a discount, but rather later on we should also be providing incentives for quality of care, or for the, because again, one of the indicators as provided in the law is it should be performance driven and performance based. So we are, I think kung akong titingin sa pagtingin ko dyan is really more on the incentives on the performance based and all, but not on the discounts or disincentives.
Thank you, sir. Thank you for that clarification. So thank you, Doc Ish, for answering the questions, and of course for your very comprehensive lecture for us. So now let me turn over the floor to Mr. Hex Orbeta.
Thank you, Doc Annie. Before we end, in behalf of QualiMed Health Network, we would like to present this e-certificate of appreciation to Dr. Israel Pargas for his expertise and valuable role as a speaker during the webinar entitled Understanding Universal Healthcare and Diagnosis-Related Group. Given this 22nd day of July via Zoom virtual event, originally signed by Dr. Gina Nazareth, our Vice President for Medical Affairs of QualiMed Health Network, and Ms. Margaret Benzon, Group COO of QualiMed Health Network, and of course, Mr. Jaime Ismael, President and Chief Executive Officer of QualiMed Health Network. Thank you, Doc Ish.
Hi, thank you very much. Thank you, everyone. If there's a need for more, then you can always request naman for any updates later on.
Yeah.
Thank you.
Okay. Lastly po, we would like to present this e-certificate of appreciation to Dr. Annie Batangan for her expertise and valuable role as a host and moderator for this webinar entitled Understanding Universal Healthcare and Diagnosis-Related Group. Also given this 22nd day of July via Zoom virtual event, and originally signed by Dr. Gina Nazareth, our Vice President, and QualiMed Health Network for Medical Affairs, Ms. Margaret Bengzon, Chief Operating Officer, and Mr. Jaime E. Ismael, President and Chief Executive Officer of QualiMed Health Network. Thank you, Doc Annie.
Thank you, Sir Hex. Thank you, Doc Gina. Thank you, Doc Ish.
Thank you po. Thank you.
Doc Gina, any last words po?
Thank you very much, everyone, for attending. We will provide you, for those who were not able to attend the first part of this webinar series, we will provide you with a recorded link through your different medical societies. I also would like to thank again Doc Ish, sa uulitin ulit. And then, of course, Doc Ish, salamat ha.
Apo. I can also provide, Dr. Gina, I can also provide a copy of the presentation ng
great.
both presentations po. I'll
Ay,
email it to
thank you
you.
po, Ish. Oo, pati yung sa UHC na rin,
Apa,
nadamay ko
yes
na rin,
pa,
ha?
apa, yes pa.
Thank you very much. Also, I would like to thank the different medical societies are present here. Si Dr. Caroline Montano, the president of Tanawan Medical Society, Dr. Ludovice, the president of PCP Southern